The scope of practice for the PMHMP is based on an understanding of foundational core concepts and theories. Recovery is the single most important goal in the transformation of mental health care of the past 2 decades. 4 major dimensions of recovery include health, home, purpose, and community. The PMHNP role interventions follow evidence-based practice guidelines, are always client goals directed, and take into account the client's ethnicity and culture. The PMHNP help clients to recognize strengths, set attainable goals, and have hope for their future. A key part of the PMHNP role is to use empirical evidence in educating their clients, families, and the community about mental health, psychiatric illness, and effective management of illness. This role oversees and guides the psychiatric mental health nurse in designing evidence-based health information and educational programs that are geared toward consumer learning needs, ability, and readiness to learn. This role cares for people with co-occurring medical and psychiatric disorders. Principles of mental health recovery are integrated into all levels of mental health care. Classification of Psychiatric Disorders, DSM-5. Prior to May of 2013, psychiatric disorders were classified using the standard criteria for the Diagnostic and Statistical Manual of Mental Disorders, DSM-5-TR, American Psychiatric Association, 2000. Unlike previous editions, the DSM-5 does not use multi-axial classifications. The DSM-5 classifies mental illnesses on the basis of specific criteria that have been tested for reliability when used by mental health professionals, and it emphasizes dimensional assessments. The therapeutic relationship assumes that the client and nurse enter into a mutual interactive interpersonal relationship specifically to focus on the identified needs of the client. The therapeutic relationship are focused on the client's needs and are goal-directed, theory-based, and open to supervision. The following are a few characteristics of a therapeutic relationship: genuineness, acceptance, non-judgment, authenticity, empathy, respect, and professional boundaries. The therapeutic relationship has specific and sequential phases. Transference and countertransference are key concepts in the nurse-client relationship. Transference is displacement of the feelings for significant people in the client's past onto the psychiatric nurse practitioner in the present relationship. Countertransference is the nurse's emotional reaction to the client based on her past or his past experiences. Signs indicating the presence of countertransference in the PMHMP include an intense emotional reactions, positive or negative, on the first contact with the client. Recurrent anxiety or uneasiness while dealing with the client, uncharacteristic carelessness in interaction and follow-up with the client, difficulty empathizing, resistance to others treating or interacting with the client, or preoccupation with or dreaming about the client. And that would be signs of countertransference. Phases of a therapeutic nurse-client relationship. There are introduction, working, and termination. The introduction is part of the orientation phase. So introduction is orientation. The nurse's action is creating a trusting relationship, establish professional boundaries, establish the length of anticipated interaction, and providing diagnostic evaluation and setting mutually agreed upon treatment objectives. The common client behavior in regards to the introduction phase is initial hesitancy by the client to participate fully in the assessment and treatment planning approach. And sometimes they display avoidance. Throughout the working phase is also called the identification and exploitation phase, and the nurse's action is to clarify the client expectations, implement treatment plan, monitor health, undertake preventative health care, measuring outcomes, evaluating outcomes, and reprioritizing the plan and objectives. The common client behavior regarding the working phase or the working identification and exploitation phase is transference. The client might resist care practices, and the client might resist change in the working phase. During the termination and resolution phase, the nurse's actions are reviewing the client's progress, establishing long-term plan of care, focusing on self-management, disengaging from the relationship, and referring the client to other services as needed. The common client behavior in response to the termination phase is the client resistance to termination. There could be some regression. There could be some reemergence of symptoms or problems. Going back to countertransference, the other signs of countertransference, which again is the nurse's emotional reaction to the client based on their experiences, some examples or some more examples are frequently running over time or cutting the time short with a client, depression or other strong emotions during and after interaction with a client, feedback from others regarding over-involvement with a client. The psychiatric mental health nurse practitioner is expected to monitor their own reaction to the client constantly and assess for the presence of countertransference. If identified, countertransference is usually dealt with through the supervisory process and in taking coworkers about the issues. Providing in peer-to-peer supervision relationship examines interpersonal dynamics inherent in the psychiatric mental health nurse practitioner relationship with a client. Erik Erikson's Stages of Human Development. Infancy is birth to 1 year. It's trust versus mistrust. The indications of development mastery is the ability to form meaningful relationships, hope about the future, and trust. Indications of development failure are poor relationships, lack of future, suspicious of others. In early childhood is 1 to 3 years is autonomy versus shame and doubt. The mastery of this is self-control, self-esteem, and willpower. Failure is poor self-control, low self-esteem, self-doubt, lack of independence. That's early childhood 1 to 3. Late childhood is 3 to 6 is initiative versus guilt. Mastery is self-directed behavior, goal formation, and sense of purpose. And failure is lack of self-initiated behavior, lack of goal orientation. School age is 6 to 12 years old, industry versus inferiority. Mastery is ability to work, sense of competency and achievement. And failure is sense of inferiority, difficulty with working and learning. Adolescence is 12 to 20 years old, 12 to 20, and it's identity versus role confusion. Mastery is personal sense of identity. Failure is identity confusion, poor self-identification in group settings. Early adulthood is 20 to 35, which is intimacy versus isolation. Mastery is committed relationships, capacity to love, and failure is emotional isolation and egocentrism. Middle adulthood is 35 to 65, which is generativity versus self-absorption or stagnation. Mastery is ability to give time and talents to others, ability to care for others. And failure is self-absorption, inability to grow and change as a person, inability to care for others. And late adulthood is greater than 65, which is integrity versus despair, is a developmental task. Mastery is fulfillment and comfort with life, willingness to face death, insight, balance, perspective on life events. And failure is bitterness, sense of dissatisfaction with life, despair over impending death. Foundational theory supporting the PMHMP role. Psychodynamic psychoanalytic theory with Sigmund Freud from 1856 to 1939. The focus is on concepts of intrapsychic conflict among the structures of the mind. Initially designed to explain neurosis and conditions of high anxiety such as phobias and hysteria, theory later expanded to include normal and abnormal development and personal development. Basic tenets of psychodynamic theory are psychoanalytical theory assumes that all behavior is purposeful and meaningful. All behavior has meaning. Principle of psychiatric determinism, even apparently meaningless, random, or accidental behavior is actually motivated by underlying unconscious mental content. For example, a person who forgets where he parked the car because he really does not wish to go wherever he is headed. Most mental activity is unconscious, urges, feelings, and fantasies that would be unacceptable to the person's values if consciously experienced. Conscious behaviors are choices are affected by unconscious mental content. Childhood experiences shape adult personality. And this is having to do with psychodynamic, psychoanalytic theory with Sigmund Freud. Examples of typical age of onset for common psychiatric disorders are intellectual disability is usually infancy until evident at birth, ADHD usually adulthood by age 12, schizophrenia 18 to 25 for men and 25 to 35 for women, major depression is late adolescent to young adulthood, and dementia is most common after the age of 85. Freud's psychosexual stages of development. The oral stage is 0 to 18 months. Primary means of discharging drives and achieving gratification are sucking, chewing, feeding, and crying. The psychiatric disorder linked to failure of this stage is schizophrenia and substance abuse and paranoia. The anal stage is 18 months to 3 years. The primary means of discharging drives are sphincter control, activities of expulsion and retention, and the psychiatric disorder could be depressive disorders. Phallic stage is 3 to 6 years old. Exhibitionism, masturbation with focus on Oedipal complex castration, anxiety, and female fear of lost maternal love. And the disorder could be sexual identity disorders. Latency stage is 6 years to puberty, peer relationships, learning memory, skills development, socialization. And the failure would be inability to form social relationships. That's latency stage, 6 years to puberty. And genital stage is puberty forward, integration of synthesis of behaviors from early stages, primary genital-based sexuality, and failure is sexual perversion and disorders. The primary psychic structures that make up the mind and personality are responsible for mental functioning. The id contains primary drives of instincts, urges, hunger, sex, aggression, or fantasies. Drives are largely unconscious, sexual or aggressive in content and infantile in nature. Operates on the pleasure principle, seeking immediate satisfaction, is present at birth and motivates early infantile actions. That's the id, is present at birth and motivates early infantile actions. The id says, I want. ID, id. The ego is I think. So the ego contains the concept of external reality. Rational mind responsible for logical abstract thinking, functions in adaptation, mediates between the demands of the drives and emotional realities, operates on a reality principle, begins to develop at birth as infant struggles to deal with environment, responsible for use of defense mechanisms. The ego begins to develop at birth and responsible for the use of defense mechanisms. That's the ego. The ego says, I think, I evaluate. The superego is the ego ideal, right and wrong. It contains a sense of conscious right and wrong, also contains aspirations, ideals, moral values, regulated by guilt and shame, begins to fully develop around age 6. So the id and the ego begin to develop at birth, and the superego begins to develop at age 6. The child becomes into contact with external authority figures such as other parents, school teachers, coaches, religious figures, and so on. The superego says, I should or I ought to, and it starts to develop at 6. Psychic structures commonly come into conflict over what to do to achieve gratification. Okay. Yep. Cognitive theory, Jean Paget believed that human development evolves through cognition, learning, and comprehending. He believed that factors such as native endowment and biological environmental factors set the course for a child's development. He described 4 stages of cognitive development: sensory motor, pre-operational, concrete, and formal operations. The sensory motor is birth to 2 years. This critical achievement is object permanence, the ability to understand that objects have existence independent of the child's involvement with them. Pre-operational is 2 to 7, which is more extensive use of language and symbolism and magical thinking. Concrete operations is 7 to 12. They use logic, develop concepts of reversibility and conservation. Reversibility is a realization that one thing can turn into another and back again. Such an example is water and ice. Conservation, that's reversibility. Conservation is the ability to recognize that although the shape of an object may change, it may still maintain the same characteristics of the object, such as clay. And formal operations is 12 years to adulthood, which is ability to think abstractly, thinking operations in a formal, logical manner. Interpersonal theory with Harry Stack Sullivan. Behavior occurs because of interpersonal dynamics. Interpersonal relationships and experiences influence one's personality development, which is called the self system, the total components of the personality traits. Understanding behavior requires understanding the relationships in the person's life. Two drives for behavior: the drive for satisfaction, basic human drives such as sleep, sex, hunger, and the drive for security, conforming to social norms of the person's reference group. When the person's need for satisfaction and security is interfered with by the self system, mental illness occurs. Humans experience anxiety, and behavior is directed towards relieving the anxiety, which then results in interpersonal security. Sullivan also describes stages of interpersonal development. Okay. Hierarchy of needs theory, Abraham Maslow. It's a health model rather than an illness model. It hypothesizes that certain needs are more important than others. States that a person will attempt to meet more important needs first before satisfying other needs. The hierarchy of needs are survival, such as water, air, food, and sleep. Safety and security needs are protection from harm, emotional and physical health. Love and belonging are affection, intimacy, and companionship. Self-esteem, self-worth, and self-actualization is achieving one's potential and being all that one can be. So obviously we're talking about the most top priority need being at the most basic level, which is water, food, sleep, and so on. Then there's the health belief model, which is Marshall Becker. The health belief model by Marshall Becker explains that healthy people do not always take advantage of screening or preventative programs because of the following certain variables: the perception of susceptibility, seriousness of illness, perceived benefits of treatment, perceived barriers of change, expectation of efficacy. Trans-theoretical model of change states that change, such as in health behaviors, occurs in 6 predictable stages. The pre-contemplation is the process, or the person has no intention of change. Contemplation is the person is thinking about changing, is aware that there is a problem, but there's no commitment to changing. So awareness of there being a problem is only in the contemplation phase. The preparation phase, the person has made the decision to change and is ready for action. Action is the person is engaging in specific overt actions to change, and maintenance is the person is engaging in behaviors to prevent relapse. Motivational interviewing is focused goal-directed therapy. It builds on the trans-theoretical model of change. Motivation is elicited from the client, and the approach is non-confrontational, non-adversarial. Self-efficacy and social learning theory, Albert Bandura. Behavior is a result of cognitive and environmental factors. People learn by observing others, relying on role modeling. Self-efficacy is the perception of one's ability to perform a certain task at a certain level of accomplishment. Behavioral change and maintenance are functions of outcome expectations and efficacy expectations. Theory of Self-Care, Dorothy Oram, 1914 to 2007. Self-care activities that maintain life, health, and well-being. Theory of Cultural Care by Madeline Leininger. Regardless of the culture, care is the unifying focus and the essence of nursing. Health and well-being can be predicted through cultural care. Caring theory by Jean Watson. Caring is an essential component of nursing. Curative factors guide the core of nursing and should be implemented in healthcare. Curative factors are those aspects of care that potentiate therapeutic healing and relationships. Therapeutic nurse-client relationship theory of interpersonal theory, Hildegard Peplow. First, significant psychiatric nursing theory. It's based in part on interpersonal theory of Sullivan. Sees nursing as an interpersonal process in which all interventions occur within the context of the nurse-client relationship. The therapeutic nurse-client relationship is central to nursing. It includes phases of the nurse-client relationship. There's orientation phase, working phase, and termination phase, as discussed earlier. Promoting adaptive responses is the goal of nursing. Behavior represents the person trying to adapt to interpersonal or environmental forces. Leadership. Nurses should be leaders and engage with health professionals to transform and redesign healthcare. The nurse practitioner is educated to lead interdisciplinary treatment teams, act as full partner in healthcare, designs, implements, evaluates, and advocates to redesign U.S. healthcare system, translates research into practice. Team leadership model. Decision number 1, should the leader monitor the team or take action? Seek out information to understand the team, analyze the information, and interpret the information and decide how to act. Decision 2 is, should the leader intervene to meet the task or relational need? Performance functions, task functions. Decision 3 is, should the leader intervene internally or externally? Assess for conflicts between group members, action to maintain group performance, assess for unclear goals, and assess for proper support. Reflective practice. Reflection uses a model or framework of systematically make sense of experience. Process to tell a story about self and others to gain insight into practice. Enhances critical thinking to problem solve and enhance clinical reasoning and decision making. It links theory into practice. Conflict resolution, negotiation, mediation, and professional civility. Conflict occurs when a person believes his or her needs, interests, or values are incompatible with others. Conflict resolution is directed by a neutral third party who facilitates a win-win situation. Negotiation is a discussion among 2 or more people with the goal of reaching an agreement. Mediation is a voluntary and confidential process in which a third party facilitates discussion to reach an agreement. Arbitration process in which a third party reviews evidence from both sides and makes a decision to settle a case. And professional civility is the behavior that shows respect toward another person. Nursing research. We'll start with critical thinking. Critical thinking is defined as the acquisition of knowledge with an attitude of deliberate inquiry, making clinical decisions based on evidence-based practice. Decreases the difficulty of choosing from conflicting or multiple recommendations when diagnosing and treating clients, and develops self-awareness through a metacognitive process to gain new insights about self and in relation to others. Research utilization is a process of synthesizing, disseminating, and using research-generated knowledge to make a change in practices, a subset of the broader evidence-based practice. Evidence-based practice is the integration of best practice evidence with clinical expertise and client values and needs. Psychiatric mental health nurse practitioners need to know the effectiveness of evidence-based interventions and select the interventions to meet the client need. Research utilization and evidence-based practice are 2 models for reducing the gap between research findings and applications to practice. Research utilization and evidence-based practice are 2 models for reducing the gap between research findings and application to practice. Research utilization process are critique research, synthesize the findings, apply the findings, and measure the outcomes. Develop a clinical question using the PICO method. P is patient population or patient problem. I is intervention. C is comparison to another treatment or therapy or placebo. And O is outcome. Systematically search for relevant research evidence. Critique the research evidence. Qualitative hierarchy is a randomized controlled trials, RTCs, meta-analysis, or systematic reviews. Quantitative hierarchy is evidence-based from systematic reviews of descriptive and qualitative studies. Make an evidence-based decision regarding implementation. Implement the change depending on the above decision. Evaluate the change. Then dissemination, which is present at local, regional, and national conferences. Publish in peer-reviewed journals. And then the concepts of interpreting research findings. Internal validity is the independent variable or treatment caused by a change in the dependent variable, which is the outcome. External validity is the sample is representative of the population and the results can be generalized. Descriptive statistics used to describe the basic features of the data in the study. Numerical values that summarize, organize, and describe observations can be generated by either quantitative or qualitative studies. Examples include mean, which is the average of scores, standard deviation, which is an indication of possible deviations from the mean, and variance, how the values are dispersed around the mean. The larger the variance, the larger the dispersion of scores. Inferential statistics, numerical values that enable one to reach conclusions that extend beyond the immediate data alone, generated by quantitative research designs. That's inferential statistics. The examples include a t-test, which assesses whether the means of two groups are statistically different from each other. Analysis of variance, which is ANOVA, tests the differences among three or more groups. That's ANOVA. Pearson's R correlation tests the relationship between two variables. Probability is the likelihood of an event occurring. It lies between 0 and 1. And so an impossible event has the probability of 0, and a certain event has the probability of 1. P-value, also known as the level of significance, describes the probability of a particular result occurring by chance alone. So if P equals 0.01, there is a 1% probability of obtaining a result by chance alone. Ethical considerations in research. The institutional review boards, or IRBs or IRBs, ensure that the risk to participants are minimized, participant selection is equitable, adverse events are reported, and risks and benefits are reevaluated. Informed consent is obtained and documented. Data and safety monitoring plans are implemented when indicated, and overall that the rights and welfare of human research participants are protected and have the authority to approve, require modifications, or disapprove of any research activities. And that's the institutional review boards. And they also, all investigators or persons involved in research studies must take and pass a test on protection of human participants. Quality improvement. Agency-specific projects that aim to improve systems, decrease costs, and improve productivity. Provides standardized method to identify gaps in practice and systems to evaluate ways to improve structure, function, and resources in care delivery within complex healthcare systems. The Institute of Medicine's quality aims, that's the IOM, the Institute of Medicine's quality aims are safety, efficiency, client-centered, timely, efficient, and equitable. Examine internal processes. New knowledge is specific to an organization. The Don Abedian model is structure, process, and outcome. Process of quality improvement can be PDSA cycle. So that's PDSA. Plan for the change. Do, carry out the plan. S is study or examine the results, and A is act. Decide what actions will improve the process. Then there's translation of research into practice using quality improvement efforts and clinical inquiry, leading to improved systems and processes which create improved health outcomes. Just culture of safety. American Nurses Association position statement, the ANA in 2010, supports collaboration efforts among state boards of nursing, professional organizations, patient safety centers, and health systems to develop just culture initiatives. It holds people accountable for their behaviors and investigates errors. Goal of creating open and fair learning environment to design safe systems and manage choices. mindset that affects work environment to proactively look for system breakdowns and identify ways to improve the systems. The health delivery systems. The healthcare is complex and fragmented. Complexity science provides a framework to understand, design, and structure change. Focus is on the interaction of the parts and relationships. It's a nonlinear process. Quality of healthcare. The National Committee of Quality Assurance, NCQA, has developed Health Effectiveness Data Information Sets. That's HEDIS. That's Health Effectiveness Data Information Sets to measure health outcomes. Currently, 11 HEDIS measures exist for behavioral health specifically. They are antidepressant medication management, follow-up care for children prescribed with ADHD medication, follow-up after hospitalization for mental illness, diabetes screening for people with schizophrenia and bipolar disorder who are using antipsychotic medication, diabetes monitoring for people with diabetes and schizophrenia, cardiovascular monitoring for people with cardiovascular disease and schizophrenia, adherence to antipsychotic medications for individuals with schizophrenia, use of multiple concurrent antipsychotics in children and adolescents, metabolic monitoring for children and adolescents on antipsychotic medication, and the use of first-line psychosocial care for children and adolescents on antipsychotic medication. And lastly, mental health utilization. Organization of practices. With the Affordable Care Act of 2010, practices are being reorganized and redesigned to provide integrated care, including medical and psychiatric care. The client-centered medical health care home has support of the Health Resource and Service Administration, HRSA, and initiatives to provide client-centered, evidence-based, coordinated, and quality care are moving forward. Patient-centered care model. Welcoming environment. Provide a physical space and an initial personal interaction that is welcoming and familiar and not intimidating. Respect for the client's values and express needs. Obtain information about the client's care preferences and priorities. Inform and involve the client and family or caregivers in decision-making. Tailor care to the person and promote a mutually respectful, consistent, and client-provider relationship. Client empowerment or activation. Educate and encourage the client to expand his or her role in decision-making, health-related behaviors, and self-management. That's client empowerment. Social-cultural competence. Understand and consider culture, economic and educational status, health literacy level, family patterns and situation and traditions. Communicate in language and at a level that the client understands. That's socio-cultural competence. Coordination and integration of care. Assess the client's need for formal and informal services that may affect health or treatment. Provide team-based care management, and referrals as needed. Advocate for the client and family, and ensure smooth transitions between different providers and phases of care. Comfort and support. Emphasize physical comfort, privacy, emotional support, and involvement of family and friends. Access navigation skills. Provide what the patient can consider a medical home. Keep waiting times to a minimum. Provide convenient service hours. Promote access and client flow. And help client attain skills to better navigate the healthcare system. And lastly, community outreach. Make demonstrable, proactive efforts to understand and reach out to the local community. The healthcare home was defined in the Affordable Care Act of 2010 by the Substance Abuse and Mental Health Service Administration in 2015, defined the healthcare home as an approach to primary care that provides coordinated care to persons with multiple chronic health conditions, including mental health and substance use, offers a team-based care, and builds on community supports. Conflict of interest. A conflict of interest, or a COI, is a situation in which a person's financial, professional, or personal situation may affect or appear to affect a person's judgment in his or her professional responsibilities, including healthcare decisions, research, and other matters with the potential for personal or professional gain or advantage, or conversely, loss or disadvantage of any kind and the possibility of potential harm to the clients. Disclosure of potential conflicts of interest should be done at least annually and whenever new significant financial interests are received. Disclosure must be reported to employers, boards, professional agencies, and whenever it is potential for a conflict of interest. Action should be carried out to resolve potential or actual conflict of interest and reduce bias. Healthcare agencies and educational research institutes have policies and require the disclosure of any potential conflict of interest and to define the limits allowed in any relationship with external organizations and companies. A conflict of interest form indicating any financial or other relationships with products being discussed must be completed prior to any professional presentation. In addition, if any off-label uses of medications or medical devices will be discussed, this information must also be disclosed. Some examples of conflict of interest are relationships with pharmaceutical, medical supply, or insurance companies, money or gifts of any kind, referrals, or fee splitting. The rights of clients. 3 basic rights are confidentiality, least restrictive treatment, and give consent for treatment and withdraw consent at any time. Health policy development is decisions, actions, and plans to achieve specific healthcare goals from the World Health Organization definition. There's 4 components of health policy. Policy, reform, policy environment, and policy makers. Process is the formulation and implementation and evaluation of policies. Policy reform are changes in progress and practices. Policy environment is the arena the process takes place in, such as the government, media, or the public. Policymakers are key players and stakeholders. Health policies are developed through law and regulation. Branches of law, executive, implement the law, legislative, initial formulation, and judicial interpret the law. As a recap, countertransference is dealt with peer-to-peer. The way to deal with countertransference is dealt with peer-to-peer supervision relationship. Infancy, birth to 1 year, is trust in others, if not met, suspicious of others. Early childhood is 1 to 3 years, autonomy versus shame and doubt, lack of independence, low self-esteem. Late childhood is 3 to 6 years old, initiative versus guilt, if not met, lack of self-initiated behavior. School age is 6 to 12 years old, industry versus inferiority, if not met, sense of inferiority and difficulty with work and learning. Adolescence is 12 to 20, identity versus role confusion, if not met, obviously you're going to have role confusion. Early adulthood is 20 to 35, intimacy versus isolation, if not met, emotional isolation, and egocentrism. 35 to 65 is middle adulthood, generativity versus stagnation, if not met, inability to grow as a person. Late adulthood is greater than 65, integrity versus despair, if not met, bitter despair over impending death. Typical age of onset for common psychiatric disorders are schizophrenia, men is 18 to 25, women 25 to 35. Major depressive disorder is late adolescence to young adulthood. Dementia is greater than 85. The id and the is present at birth and or infancy. Same with the ego. The superego develops after the age of 6. Psychodynamic psychoanalytic theory is Sigmund Freud. All behaviors are purposeful and have meaning. Urges, feelings, and fantasies are unconscious. Conscious behavior is affected by unconscious mental content. 2 drives, sexual and aggressive. The id, immediate satisfaction. Ego, I think, I evaluate, responsible for the use of defense mechanism. The superego is right and wrong, moral values. Conflict is dealt with, defense mechanisms. The cognitive theory, Jean Piaget, is human development evolves through cognition, learning, comprehending. There's 4 stages of development. sensory motor. Birth to 2 is object permanence. Pre-operational 2 to 7, magical thinking. Concrete operations 7 to 12, logic develops. Reversibility, water, ice. Conservation is clay. And formal operation is 12 to adulthood with the ability to think abstractly. So back to Freud's defense mechanism. Repression is unconscious. Suppression is conscious. Sublimation is unconscious use of constructive activity. Altruism is meeting the needs of others. Reaction formation is action, the opposite of what you're feeling. Maslow hierarchy of needs. First comes safety, then love, then self-esteem. Lastly comes self-actualization. The interpersonal theory of Harry Sullivan. Behavior occurs because of interpersonal dynamics such as the self-system. Health belief model. Healthy people don't always take advantage of screening or prevention due to perceptual feelings regarding treatment. Trans-theoretical model of change has 5 predictable stages. Pre-contemplation, there's no intent to change. Contemplation, recognition of the problem, thinking about it but not committed to change. Pre-contemplation is decided to change and is getting ready to. Action is overt actions to change, and maintenance as behaviors to prevent relapse. Motivational interviewing builds on the trans-theoretical model of change. Motivation is elicited from the client in a non-confrontational manner. Social learning, people learn by observing others, self-efficacy, self-perception, and abilities. Nursing theories. Theory of cultural care is unifying regardless of culture. Theory of self-care, Dorothy Oram, activities that maintain life, health, and well-being. Therapeutic nurse-client relationship is PAPLO, which is orientation, working, and termination. The caring theory of Gene Watson is curative factors potentiate therapeutic healing relationships. Reflective practice. Systematically make sense of an experience. Conflict resolution is negotiation, mediation, professional civility. Conflict is needs are incompatible with others. Conflict resolution are directed by neutral third party win-win. Negotiation, discussion with goal to reach agreement. Mediation is third party assists in processing the agreement. Arbitration is a third party reviews evidence of both sides. And professional civility is respectful behavior. Critical thinking is the acquisition of knowledge with an attitude of deliberate inquiry. Research utilization synthesizes and dissemination of research-related knowledge to make it change and practice. Evidence-based practice integration of best research evidence. PICO. PICO is to develop a clinical question. P is patient or population. I is intervention. C is comparison to other treatments. And O is outcome. Qualitative is hierarchy. The number 1 is randomized controlled trials. Second is meta-analysis. Least is the expert opinion. Quantitative are systematic reviews.